Hello everyone, and welcome to the Northwest Geriatric Education Center's Geriatric Healthcare Lecture Series. My name is Barbara Cochran. I'm the director of the DeTournier Center for Healthy Aging here in the School of Nursing. But as usual, today I'm representing the Northwest Geriatric Education Center. You should have information from your site coordinators about how to log in and obtain continuing education contact hours for this series. Or specific lectures within the series. Please remember, if you haven't attended one of these lectures before, to fill out a profile form and turn that into your site coordinators. And today I'm very, very happy to introduce to you Dace Trence. She is the director of the Diabetes Care Center and a UW professor of medicine. I just realized I'm not holding this up to my mouth, so hopefully you heard the rest of that. She's also the University of Washington Endocrine Fellowship Program Director. She serves on the American Association of Clinical Endocrinologists Board of Directors, chairing the AACE Continuing Education Committee, as well as the Publications Committee. She's been on the editorial boards of several journals, including Clinical Diabetes. She's had articles published in JCEM, JAMA, Diabetes Care, and is co-author of Optimizing Diabetes Care for the Practitioner. She's director of Endocrine Days, a Pacific Northwest continuing medical education event directed to clinical as well as academic clinicians in the Pacific Northwest, as well as a co-chair of AACE's Pacific Northwest chapter. So she's a good person to connect with if you're interested in other kinds of events happening in this area. Her current interests include improving educational processes in diabetes self-management and clinical training of healthcare professionals. And today she's going to talk to us about diabetes mellitus type 1, not a disease limited to youth. Welcome.
Thank you. Thank you very much for that wonderful introduction and for the ability to talk about a topic that I clearly enjoy talking about. So having said that, I think most of us certainly recognize a picture like this as rather typical of type 1 diabetes. I don't think anyone would question that. Perhaps a little less typical, but certainly still recognizable, would be someone in their middle years. This is an athlete who's trying to climb Mount Everest, actually. But I think more and more, we're actually beginning to recognize that this is, too, is the picture of type 1 diabetes. This actually is an individual that lived in the eastern part of Washington and had type 1 diabetes for well over 50 years, actually closer to 75 years. And we actually are seeing more and more individuals like this. So if we think about diabetes overall, and I will kind of talk a little bit about type 2 diabetes because it still is our dominant form. It's where we have most of our knowledge. We're just beginning to learn about type 1 in the older individual population. But a lot of what we have learned has come from the fact that we know diabetes is increasing in incidence. If we look worldwide, actually by 2 to 5% per year, it's not a small incidence and rather increasing as time is going on. And probably it's a combination not just of diagnosis. Quite frankly, it's not that difficult to diagnose, although there are some caveats we'll talk about, but it's because people are living longer. The diabetes is better managed, and so you're seeing individuals actually living into later decades of life. The incidence of diabetes, even in children, is increasing, and I point this out simply because these children are actually coming into adulthood and coming into their later years of life, too. But there has been clearly an increase that in the incidence of type 1, as you can see over the centuries from 1920, the decades rather, from 1920 to 2000, and it actually is continuing, as I mentioned. We're also seeing that there are younger and younger individuals being diagnosed. Again, moving from the 1940s in the solid line to the dotted line, 1970s. Again, there's an increased incidence of younger and younger individuals. And again, these individuals, too, are growing into old age. Typically, the diagnosis is made in childhood, but about 25% of individuals with type 1 are diagnosed when they're in their adult years. Some even as late as the 9th decade of life. I think the oldest person that I have seen with brand new diabetes was actually 93 years of age. She'd had a son with type 1 diabetes that I'd seen for quite some time. He was in his 40s. His mother went to Florida for a vacation with her husband, became ill there, was admitted to the hospital, treated, and because it was felt that she must have type 2 based on her age, discharged without insulin. And as you can imagine, she was back in the hospital within 48 hours, and the appropriate diagnosis was then considered. So it does happen late in life, and we have a number of individuals who now are in their 80s and 90s that are newly diagnosed. If we look at the incidence, I think what's helpful is this particular study from Kronenberg in Sweden. If you look at the age ranges here, these are populations at risk, basically meaning these are the number of individuals that they have in this particular area per this decade of life. But I want to point out to you that if you look at the incidence here, look at this incidence here, new cases diagnosed compared to new cases diagnosed within the earlier years of life. So I think this reinforces that indeed we are seeing, I think let's maybe move this here, that we are seeing, again, this is a brand new diagnosis, not by any means limited to individuals who are in their younger years. Let's move this back out. And again, is it more men? Is it more women? I think, again, you can see kind of this curve of diagnosed type 1 diabetes equally type where you would expect it in the younger individuals. But then look at this particular group down here, as I mentioned, and again, very robust, almost the same number as we saw in the younger individuals. Perhaps a bit skewed in that you see more women than men. I think this just reflects the fact that there's an age differential in survival between men and women. Look, even at age 80, again, no one's safe from the diagnosis of type 1 diabetes. So what have we actually learned? Well, one thing we've learned is not to call this juvenile diabetes. It's thrilling. I mentioned that my patient who was 92 years of age, she was delighted that this was called juvenile onset, but it doesn't really reflect what the problem is. It really is something, a terminology that's old, and we should really be avoiding it. It can occur also in overweight people. Again, there's a tendency that if you're overweight and you're not the thin little pencil, that you must be having type 2 diabetes as the true type of diabetes. But it can occur actually in overweight people, not uncommonly. And again, this is something we're seeing more and more. It is best identified and diagnosed using specific immune and genetic markers. Type 1 diabetes is an autoimmune disease. It's an autoimmune disease against the cells that produce insulin. And so we should be able to measure these antibodies. Sometimes the antibodies are a little unclear. Our testing systems are not perfect for these antibodies, and we then can use genetic markers to at least give us an idea of whether this person has a low risk or a high risk for the development of type 1 diabetes. There are a number of the immune markers, as I mentioned, and we're learning more and more about ones that are available. The one that you see actually here has just begun to be recognized in the past year or two, a zinc transporter marker. This one is readily available clinically, and we commonly use it to make the diagnosis when we suspect that it's present. In fact, it's actually an antibody that if you are in your adolescent years is now pretty traditionally done to make sure indeed that the person does have type 1. But these are more likely to be available in study format. But as I mentioned, there are a number of these markers, and we'll talk a little bit more about that in the next slide or so. As I mentioned, genetic markers can give you an idea as to whether there's high risk versus a low risk. This is dependent on HLA types. Again, not readily available types of blood results that we can get, but we are fortunate, particularly in this area of the country and Seattle, having a number of individuals that are very interested in genetic markers, using them as predictors in addition to actually being able to complement a diagnosis. And we've also learned, in contrast to what I learned when I was in my training, that the way you diagnose diabetes is that yesterday you didn't have it, and today you have it, that there is actually a very long preclinical period of time. So type 1 diabetes doesn't come up overnight. The natural history of type 1 diabetes can be looked at in this particular way. If we look at the clinical onset of diabetes as defined by this yellow line down here, and time, which can be nebulous, months or years, so that's why there aren't any specific hatch marks there. there has to be a genetic risk. We just talked about that. So something in the genetic picture has to facilitate or allow the process to evolve. What then happens is that there's an environmental insult. And this is a big grab bag. We don't know what that insult is. There are many guesses. There are many people actually doing their research, and their careers are being spent in actually trying to identify this. And some of it seems somewhat at odds. Cow's milk too early, cow's milk too late in the early year of life. Is it a specific virus? Because there certainly are patterns of increased incidences of type 1 after specific viral processes, including measles, Coxsackie, a number of these. But even that may not be enough to really result in a loss of beta cell function that's significant. So many of these individuals we may not even know about. Further, the problem is enhanced by the autoimmune system being affected by that environmental insult. And this can go on slowly for many years until that critical point is reached when truly insulin is needed, and we now recognize that type 1 diabetes is present. Sometimes I compare this when talking to patients about, in order to turn the light on in a room, you need a number of things. You need that light bulb that's screwed into the socket, you need the wiring, and you need the switch to be flipped. So each one of these can be suggestive of just what I spoke about, that light bulb being the genetic risk, the environmental insult actually being the wiring, and the autoimmune attack being the person or whoever flips the switch. So it's a three-pronged process. You can then see, though, that perhaps this process, if we look at it over time, if there is never another environmental insult that occurs here, you may see that this line continues flat over a period of time. So we do see sometimes people who have the positive antibodies, but never to the point that it affects their beta cell production, their pancreatic production of insulin, to the point that you truly are diagnosed as diabetic. And you wouldn't know this unless you really looked in specific patterns, certainly patients or families who already have had an incidence of type 1 diabetes. Sometimes that environmental insult can be very sudden and very brisk, and you can see that autoimmune attack occur earlier, but this is not the typical pattern of type 1 diabetes development. As an example, this is just a representation of a glucose tolerance test, a test to actually look at the reserve of insulin through measuring what happens to blood sugar after being given a large sugar load. And this is in a family where a brother already had had type 1 diabetes. So the beginning here of the load and the stress test, if you want to call it, started here in 1960 roughly. And then you can see each year the test is repeated, and each year the blood sugar goes up higher. So this is really over the course of 6 years in this particular situation. But we also know from, again, studies in Sweden where, again, in certain communities, the blood sugar is actually followed from day number 1. Genetic markers are being actually checked in day number 1 of life. And then over a period of time, you actually can see that there's a latency period, not uncommonly, of 9 to 10 to even 11 years. So this is not a sudden disease. The downside to that, unfortunately, is that we don't have much that we can offer individuals at this point. What does it tell someone that, yes, you have a high risk of developing type 1 diabetes, we know you're on the path, but there's nothing we can do about it. Kind of a difficult conversation to obviously have. What else can we use to make the diagnosis of type 1? Well, this is a test that has some popularity, Cpeptide. When you think of the production of insulin at the pancreas, you can't really think that insulin could be freely released. If that would be kind of disastrous, there has to be some control. And the control is that when it's released with a carrier protein called Cpeptide. So as insulin is needed at specific cells, that insulin then is cleaved chemically from its carrier, and rather than having to measure insulin, which can be more difficult testing-wise to do, Cpeptide can be measured, which is a much easier measurement. The problem with this is that, although the thinking is correct, if I'm seeing somebody with type 1, their Cpeptide should be low. Unfortunately, there is still insulin production that can result in a fairly normal Cpeptide in the early diagnosis or the early course of type 1. And it's a very misleading type of test that I'm seeing unfortunately is losing the popularity it had before. So it turns out if you look even at people who've had type 1 diabetes for some 50 years or more, even they will produce a little bit of insulin. So if you're trying to think, okay, I can measure that production of insulin through measuring Cpeptide, the Cpeptide is going to be very low, but it still will be present. So again, it's something to kind of keep away from unless you're looking at diabetes that's been well into its course. The predictive value of developing type 1 diabetes is based on those same antibodies that I just mentioned. So we can look at the single antibodies, as already we've gone over, all of the ones here that we have gone over. But you can also then begin to look at what happens when you begin to measure two antibodies. This, you can imagine, is a particular interest in individuals where there are familial type 1 diabetes, 20% of which actually will be type 1 diabetes, 20% will be familial. And so individuals in the family would like to know, am I at risk? What should I be planning for? What should I be thinking about? And these actually can be used in a predictive fashion. It's not 100% predictive, but at least, again, you can give that individual the information as to high versus low risk, and then begin the screening process or set up at least a sequential lab testing system or series for these individuals to then be identified. So having identified the person, having made the diagnosis, what are the goals of treatment? Well, we can divide them into a couple of different goals. One certainly being short-term, symptom control, fatigue, weight loss, polyuria, having to go to the bathroom a lot, polydipsia, being thirsty a lot, and frequent infections. These are oftentimes yeast infections, urinary tract infections, skin infections, yeast particularly with regard to vaginitis, urinary tract infections, very common, certainly skin. But this really stands out. I saw somebody actually this morning whose main concern was, I can't drink enough water, and I can't spend enough time in the bathroom getting that water off my system. He was actually just newly diagnosed today with type 1 diabetes. We also look at metabolic stability. You want to keep that person out of ketoacidosis. You certainly want to have them feel comfortable with regard to continuing to think clearly. Certainly such endpoints such as coma or even death should be avoided. So metabolic stability following symptom control. Increasingly, we also start thinking about long-term prevention of complications, the macrovascular complications, the eye, the kidney, the nerve complications, and macrovascular, particularly as the person becomes older. This becomes a key concern with cardiovascular disease. So we're talking the prevention of heart attacks, strokes, and certainly peripheral arterial disease. How do we do this? Well, you have to have some kind of a target. The A1C is really an average measure of blood sugar over roughly 3 months' time. It's really still our gold standard for looking at whether control is good versus acceptable versus not so good. And yet there is controversy as to what the optimal target is. If we take everyone across the board, the optimal target for the AAC, the American Association of Clinical Endocrinologists, is less than 6.5. The Europeans, that next EASD, European Association for the Study of Diabetes, also 6.5. The American Diabetes Association is less than 7. And so you might say, well, gosh, well, which one should I follow if all of this is really out there as guideline? Well, without diabetes, 6% or less than 6% should actually be what you should see. And the problem is sometimes using these as good guidelines, but recognizing that there is, unfortunately, a barrier. And that's a pretty big barrier, particularly as people get older, and that is hypoglycemia. So all of these associations have tempered their recommendations, saying, well, these are great goals. Let's get those A1Cs in these values, but let's also prevent hypoglycemia. And if you are having a lot of hypoglycemia, back off. And back off to a more comfortable level. A1C of 6.5%, well, let's actually go back to 6%, would be an average blood sugar of 120 or less. 6.5% would be roughly about 135, and a 7% would be an average blood sugar over the preceding 3 months of about 150. So it gives you some translation as to what those blood sugar targets would be in hard numbers. Why do we look at good control? Well, this is really our major study that has withstood decades now of scrutiny, and it continues to have a cohort that is being followed. The Diabetes Complications and Control Trial, or the DCCT, has really been the foundation for our approach to the treatment of diabetes. The patients that were enrolled all had type 1 diabetes. You can see about 1,400 there, divided roughly equally into individuals and looking at primary prevention, so no complications, secondary intervention, where there may have been a little bit of eye disease present, a little bit of protein in the urine suggesting a little bit of kidney involvement, so that they couldn't really be called primary prevention. But then they were also divided up into a conventional versus intensive treatment group. What does that mean? Well, the conventional group, do whatever you're doing. We're just going to follow you along. The intensive group, really intensively being followed with a goal of trying to get their A1C. The goal was initially in the 6s. So what happened? Well, you can see the design here. So just basically the conventional, let's not get any symptoms of hypoglycemia, and let's not have the blood sugars run high. We'll stay with 1 to 2 insulin injections per day, which was the standard of care at that time. Monitoring, yes, but monitoring through urine at that time, although the change was to finger stick over the years that were actually, the study was in place. Diet and exercise education was given, but it wasn't intensive, and let's just have you come back like normally. We have people come back every 4 months or so. In the intensive group, again, you don't want to cause hypoglycemia. And again, these are taken from the European reports here. But the goal was to try and get the A1C, as I mentioned, into a very, very tight control. They were required to have a minimum of 3 insulin injections per day or be on a pump. They had to check their blood sugars frequently using finger stick approach. They were hospitalized initially just to give education intensively. They were followed frequent visits with a dietitian to the point that some dietitians felt they had nothing more to discuss. Monthly clinic visits. I mean, truly an intensive program. These individuals were followed, actually, I think there were 1 or 2 that actually ended up in jail for various reasons. They were followed into jail. I mean, they were literally hounded with weekly phone calls. How are you doing? What are your blood sugars? What should we do next to kind of bring everything back into control? So really a lot of energy placed into this study. But it paid off. And it paid off both for the primary prevention and secondary intervention groups. If we look here at specifically eye problems, the intensive being in the blue, you can see that they developed their complications at a much slower rate than did the people who had the conventional treatment. If we look at those individuals who already had a little bit of eye problem to begin with, again, over time, they did very, 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 very well. Let's move this over here. Secondary prevention, again, the same kind of distinct difference between intensive, benefiting people more so than just conventional, across the board. And these really were very impressive numbers. I think most of the time we're happy if we get values of difference that are maybe 10%, 20%, but you can imagine a 76% decrease in the development of eye problems. Over 50%, actually, if you look at problems already are there. Kidney problems, I mean, these really are impressive numbers, and have actually withstood the test of time as this particular group has been followed beyond those first initial years. But what happens? Well, I mean, you can't keep calling people weekly, year after year. That's not reasonable. I don't think people would talk to us even if we did. Caller ID and answering machines being in place right now. So after the very intensive initial follow-up, they were told, okay, we're just going to see what happens to you. We're not going to intervene in any way, not going to change your therapy in any way. Go back to your doctor that was following you for your diabetes, but we just want to know what's happening to you. And so the study, the Diabetes Complications and Control Trial, has now continued. And now it's really an observational trial called the EDIC trial. You'll notice immediately what happened. The intensive group, A1C, blood sugar control, rose. It wasn't as good anymore. But interestingly enough, in the conventional group, they actually have done better. They're both now at about the same, so running an A1C of 8%, which is roughly translatable to an average blood sugar in the range of about 180. So now what happens to these individuals as they really are very similar? Well, as it turns out, you follow them out to 10 years, and you're still seeing improvements with regard to both eye and kidney. And even more, if we start looking at some of the things that begin to come into place, and I apologize for the blurriness of this slide, we now begin to look at what happens with complications that are even more important, and that is specific to blood vessels, heart attacks, strokes, and the peripheral arterial disease. So now you see that the people are being followed well into year 20, 21, and what do you see? It's that same kind of difference between conventional versus intensive treatment. This despite the fact that their blood sugar control really now is basically the same. So what's the take-home message? Well, the take-home message is that if you really want to make a difference for these individuals with type 1, you need to really early on be on top of the blood sugar. That this is something that really translates lifelong into better control. And it actually makes a difference no matter what age you are. And again, if we take a look at the individuals who are in the 50 to 60 year range, 65, this is death from any cause. These are males up here, females down here. Again, let's just take a look at this. And this is a forest plot. So anyone to this side of the curve does better with intensive control. Anyone on this side does not. And I think it's pretty obvious that if you look, all the lines are on this side. So even as one ages with type 1 diabetes, you still continue to reap the benefit of good blood sugar control earlier on. If we look even at cardiovascular cases specifically, as I mentioned, again, it's pretty hard to ignore the very positive effect that good blood sugar control early on has. Again, whether you look at the 50 to 64-year-old range, the over 65-year, and whether you're a male or female, again, the benefits are pretty dramatic in terms of reduction of complications. And this is just another way of looking at the same information, but taken from a different study. This is from the Swedish registry. Again, this is basically just an ongoing follow-up of people who have type 1 diabetes and looking at how they do. And again, we're seeing that people just benefit more and more from the lower A1C, translatable to better blood sugar control. As your blood sugars go up, you actually have a higher risk of death from any cause, a higher risk from cardiovascular disease. So again, that same kind of message keeps coming through, not just from the DCCT, which was a US-based study, but also, I think, from other studies that have corroborated those results. Mortality overall, again, that differential between intensive and conventional treatment, you notice that we're now out to about 30 years of follow-up. So this really is rather dramatic that it continues. Those curves are not coming together in any way or shape. One has to kind of keep in mind that there are relatively few deaths because people who enrolled in this were enrolled when they were in their 20s and 30s, and so we're just beginning to see people hit 60s and 70s. But this metabolic memory that's referred to is extremely powerful. And we also can have a sense of what can contribute to an increased risk. So certainly smoking, not too surprising. Diabetes if it's diagnosed at a later age, perhaps because of comorbidities and other problems such as blood pressure, lipids, and also if people have difficulty with kidney function, fall off, this too contributed to, again, a greater risk. So we're seeing a little bit of a trend. Certainly the protection or protective effect of better blood sugar control really over decades, even though the good control may have been decades ago, but also recognizing some of the risk factors that can contribute to more complications with type 1 in the older individual. And again, another way of looking at, however, the price to pay. Nothing comes without a price, and I mentioned hypoglycemia is really the biggest price. So as you look at individuals, again, looking at, here's my pointer here, the retinopathy that we talked about, the risk of going up with poor blood sugar control, with better blood sugar control, hypoglycemia becomes more of a factor to consider. So that some people may have to hover in this area, because this is just too much of a price to pay. We'll talk a little bit about hypoglycemia in the older population. So if we look at various agents, and of course for type 1 diabetes, we're looking at insulin at this right side of your graph here. Hypoglycemia is very, very, very common. Whether you're using just basal insulin alone, which would be more likely to be in a type 2 individual, or a more typical basal bolus, the incidence of hypoglycemia is really something that we're beginning to recognize as extremely important. So does it make a difference in terms of what kind of insulin program one has? I mentioned basal, which is just a long-acting insulin, background insulin, versus basal plus bolus, which is a bolus for food. There's not a huge amount of difference here if you look between the programs. And granted, this is type 1 compared to type 2, but I think it tells us this is going to be a mixture of insulins, short and long-acting. This is just going to be basal background insulin. This is basal embolus, and this is primarily mixes. This is really very difficult to tell. There's a significant difference between this. Insulin does cause hypoglycemia, and again, it's the main barrier to really use. There are many definitions of hypoglycemia, and I don't want to belabor all the definitions. Certainly what we're most concerned about is here right on the top. That's the severe hypoglycemia, which by definition requires assistance to treat. Not so much when someone is able to appreciate that they're low in blood sugar, they're beginning to sweat, they're noticing they're feeling a little shaky, and they're noticing that they could eat the paint off the walls, they're so hungry. I think these kinds of hypoglycemias are important, but they're recognized and treated. What we worry about is this in particular because of its potential to cause damage to the person as well as damage to those around that person. Much of hypoglycemia, unfortunately, is unappreciated. So we worry about a condition called hypoglycemia unawareness. This is something that oftentimes accompanies the individual who has a lot of hypoglycemia frequently. It's as if the body can't recognize that the blood sugar is low at, let's say, a blood sugar of 60, because the person's at 60 all the time. It requires that they drop to 50 before they begin to recognize that something is quite wrong. And so I think, again, it's not very well appreciated how often this can actually occur. If we look at patients with type 1 diabetes compared to all patients combined, or even type 2, there's a little bit of difference, obviously because you're using insulin only here, but I think if you recognize that 50% may not be able to recognize it as defined by continuous glucose monitoring, clearly it is a big concern. How often does it occur? Well, again, that severe hypoglycemia that I talked about in type 1 versus a milder in type 2, I would say, daily to about once a week in individuals with type 2. Once a month, again, not a small percentage by any means, and very few people will only have a very few episodes. So this is a huge number if you think about it. It's daily to about once a week on an insulin program. Pretty impressive. What about in those over 65? We don't have a lot of data in type 1 individuals in this age range, but we have just begun to learn. This is from a report that came out just last year about type 2 diabetes. And if you look at, this is actually looking at hospitalizations, so this is ER visits plus hospitalizations for hyperglycemia, this is in the red, hypoglycemia, low blood sugars in the blue, over roughly about a 10 to 12 year period of time in the Medicare population. You can see that hyperglycemia certainly is overall still more predominant cause for hospitalization or ER visit than hypoglycemia. This is all ages, and you can see the huge numbers of individuals in the database. But if you now begin to look at the 65 to 74-year-old, look at how close those numbers are for both hyper and hypoglycemia. So we're seeing as many hospitalizations for low blood sugars as for high blood sugars. And of concern was this particular finding, that the 1 year post-admission mortality rate for hypoglycemia was actually 20%, indicating it is a significant problem. When does it typically occur with diabetes? Well, again, if you look at this big pie chart in the blue, when you look at 50% of it occurring during sleep, that's quite frightening. It's quite frightening to individuals who are on insulin, and it's a major reason for people to actually cut back their dose, whether we as clinicians have advised them to do that or not, and then to get the dose back up again because hyperglycemia then becomes an issue can be quite concerning. I think this is because clearly 1 out of 5 of non-severe hypoglycemia occurs at night. Fortunately, much of this occurs when people are awake and hopefully can appreciate it, but it is a major, major factor in this particular part of the day. What are economic consequences of hypoglycemia? And again, the data reflect type 2 diabetes because we just don't have it for type 1. I think if you look at a 4-year retrospective analysis, as in this particular study, this is a rather amazing cost. And it's a cost that really, as you can see, defined per year, particularly in those people who are older aged. So look at again at the age limit, age over 65 without hypos versus those with hypos. I mean, it's almost a doubling of the cost for these particular patients. And this relates to loss of work, loss of hours at work, sick days, the consequences of just having to go to the ER, being hospitalized, not a small concern. And again, hospital admissions, mainly type 2, where we have information. Just to point out, 25% of hospital admissions for diabetes or for severe hypoglycemia, the mortality issues that are particularly related even with oral agents, and this becomes a concern. When you look at hypoglycemia, potentially, and this is underestimating how many serious events there may be on the road per month, 45 is clearly an underestimate, but it's enough to make one recognize that all that we recommend for treatment of high blood sugars comes with a pretty serious potential price. So what about some of the hassles in diabetes? Diabetes is expensive. It's a very, very expensive disease, particularly for the Medicare people who look at costs of treatment. This is why we have to fill out forms specific to strip numbers for individuals, whether they're on insulin or not on insulin. You require also looking at what other equipment is provided, whether people should have access in their senior years to all meters or all strip types. A lot of this is a huge hassle, and actually for us as clinicians delivering care, it tends to be just a multi-challenging problem. We have a lot of meters to choose from, meters that can facilitate individuals who want to look at every single detail, and many of our over 65-year-olds really want to look at plots and look at their glucoses, and they come in with graphs. We have meters that can be more discrete, but offer the ability to have a light feature that can light up a screen so you can see this better, but also have a little light here so you can see the strip better, particularly in Seattle. You can imagine this is popular in the middle of the winter. We have meters, again, that allow the ability to look at a much larger screen so that it's much easier to see with a relatively small amount of blood, and again, quite discrete. We have meters that don't do a whole lot except just give you a big screen with a number. We have meters that are big, so for the person who has arthritis, who has dexterity problems, and wants to hold something, not only can they have a meter that's larger that fits into the hand, but it's also a meter that has the strips, not something you have to individually put into the meter because these are small, but you can put the wheel into the meter and then push a button and the strip comes out and come out actually up here, and you can then just use it to get your drop of blood on. We also have meters that will do the same thing. This is actually with a little drum device, but allows the ability to put your Lancet and clip it on so that you're carrying everything in one package. So meters can be used to facilitate whatever needs there are. Low capacity for vision, dexterity issues, but the problem is using the meter. And so when you look at meter downloads, these would be the kind of records that we can get right from the meter itself. It doesn't really require the patient to be writing down blood sugars. And we look at a number of things. We look at time of day. We look at when people are checking. So this is a person who's checking predominantly in the morning, less so as the day goes on, and not at all in the afternoon to bedtime. So we have a skewed view of what's happening with the blood sugars. We can look at what the average is with regards to this period of time, and I think all of you would probably agree if you saw numbers like this is not doing very well. We have the ability to actually define low blood sugar events, high blood sugar values, high blood sugar events. So this is a person where the data would tell us that we need to be doing a little bit more aggressive insulin dosing, and perhaps also look at other factors coming into play with control of type 1 diabetes. This is another person, another reading, download. Look at the difference with regard to the number of checks. This person, this is for 4 weeks, is checking typically in the range of about 3 to 4 times a day. And they're also checking at different times of the day. So this kind of meter use gives you a lot of information because you can see when there may be a problem requiring insulin adjustment. So if midday they're running in the 140s and they're starting out their day in the 120s, they may need a little bit more insulin to cover their breakfast meal. Similarly, as we look into the mid-afternoon and we look at bedtime, you can base dosing decisions on the insulin needs that this person may have based on records. So we really depend on these glucose meters a lot. We want to have people really think of their insulin use in a very physiologic sense. What do I mean by that? Well, if we think about insulin, insulin has different functions. As you're listening to me and I'm giving my talk, your insulin is being pumped out to actually facilitate the energy required to listen, to make notes, to think. So there's always a little bit of what's called background or basal insulin that we have that must be there for function. But as you can imagine, there are times when we need a little bit more insulin. So here's breakfast, as you can see. Little blip there requiring more insulin. Here's another food, and here's a third food at dinner time. I think my little pointer is... Oh, okay, thank you. So breakfast again, lunch, dinner. There may be a little snack. This person didn't have a snack, but the little snack would also have a little bit of a blip here if that snack was eaten. So the goal of an ideal insulin program would be to try and mimic this kind of a normal secretion pattern. So therefore we define insulin use as basal or background. We define bolus as something associated with food. Or we can also actually combine it with correction. Correction insulin being something, again, you can give with food, or it may be something given independently, particularly if someone has a high blood sugar in the middle of the afternoon or, let's say, before bedtime. So there are different kinds of insulin terminologies that we use in facilitating a program. Why is that important? Well, because we have a lot of different insulins that we can use. So if we look at our early insulins, which are really quite limited, we would have an insulin that we would give, regular insulin, at the time of the meal. Didn't really work very well because most of the food was absorbed here, so what does all this insulin over here do? It actually doesn't do very much except increase the risk of hypoglycemia. And that was our regular insulin. If we look at basal insulin, certainly that function was a bit accomplished by even what we would call our food insulin. And we would have MPH, or lenti insulin, which we considered a kind of basal insulin because it was long-acting, but would also obviously cover some of that meal and would begin to cover lunch, which was eaten here. So these insulins had a whole bunch of different functions, and you can imagine some of the challenge in achieving any kind of control consistently with this particular pattern of activity. So we've moved forward in our thinking about, well, let's think about that physiologic profile I showed, and let's think about giving insulin with each meal, and then let's think about insulin that we can use overnight as a basal insulin. So there is some progress being made here, not perfect, because you still had to worry a little bit about some of these dips and the duration of effect of this insulin, which then resulted in the creation of a much more physiologic approach. So now we have a shorter acting insulin, so the goal is to really cover that particular meal. cover this particular meal, and not have this long drawn-out effect, and also then having this background insulin, which you see depicted in the white line. So we've moved forward in being able to have insulins that, again, not quite ideal, but really reflect more the need of the individual with type 1 diabetes. Well, this is great, but certainly sticking oneself is not popular. Again, with our new patient this morning, giving 2 shots was a little bit of a challenge as a recommendation. Giving 4 shots as something that would be immediately something to do was a very difficult and, quite frankly, impossible sell. We do have some aids to give insulin, and these are insulin pens. These are a variety of different pens. They're clearly more convenient to use than the traditional vial and syringe. People can carry them around, put them in a backpack, put them in a purse. You're much more likely to be able to feel comfortable taking this out when you're in a restaurant and thinking about what I should give, what insulin and what dose to give for my meal, than taking out a syringe and a vial. In fact, we have many people who outright refuse to use syringes in public because obviously we have a little bit of a connotation regarding other drugs that are used with syringes in public. So this offers at least an alternative to individuals. It certainly is also easier to use for those who have the visual or motor skill impairments. We have people with Parkinson's where getting that syringe into a bottle or vial of insulin would really be heroic, even though we sometimes have little tricks of the trade with regard to putting the vial on the table and then using the syringe, and look at some of the other little things that we have as aids for this, but it can be really quite challenging. Needles may be more comfortable because you're not having to put it into a rubber stopper to get into the vial of insulin. Most insurance companies will cover the insulin pens, but as always, there's always something that is a problem, and minimally they're twice as expensive, sometimes much, much, much more. We also can deliver insulin through pumps, and increasingly we're seeing more and more individuals actually into the Medicare post-age using insulin pumps because they've been started on pumps earlier, and they're used to pump delivery of insulin, and they would like to continue it given what they have learned in the management of their diabetes. And these are just a small sampling of pumps. Again, the problem being with these pumps that they are expensive. They tend to sometimes come and go. This one has come and gone. This one's been modified and improved. This one is still with us. And we're still looking for the most user-friendly pump that one can get. Pumps, fortunately, are covered for those in the Medicare age with type 1, providing that you do actually, interestingly enough, a Cpeptide. That is low. Remember I said that Cpeptides aren't always the best in the early diagnosis of diabetes, but this is what Medicare has challenged us with. And they also will at times allow some of the antibody markers, although they don't like to have those done quite as often as they did in the past. And what do pumps do? Well, pumps really give us the opportunity to really manage that physiologic approach much better. So you can see the boluses that can be given with a pump. There's always insulin dripping in, and you have the capacity to change it so that maybe that person overnight needs a little bit less insulin, something we can't manage with insulin injections because once you give that insulin, you're stuck. That insulin is in your body. You cannot take it out. Whereas with a pump, you can turn the pump down and you can turn the pump off and stop the insulin altogether. So a lot more flexibility. But a lot more cost, too, and I'll mention. What else do we have? And I see there's a little misprint here in glucose monitoring. Well, fingerstick testing basically gives you point in time. So here's an individual from 9 a.m. to 9 p.m., actually looking at their, or 9 a.m. actually the next morning, looking at fingersticks and their results. So here, when they woke up, they had about 120, looking pretty good. So here's a late lunch, about 1 to 2 p.m., looking pretty good. So you think, gee, they're doing pretty good here. Well, we had a little blip up. That was after dinner, but able by nighttime to get it back down. Again, you'd think, gee, this person's not doing too badly. All I need to do is just talk about what insulin dosing we should adjust to get this one down. And then they don't check, and you think, oh, they did great this whole next day. Very deceptive, as we have learned, because what one then can learn with continuous sensing is that the pattern may be quite different. You have a low, which really may not have been appreciated by the person. You clearly have high that began long before this point was actually tested. Another low down here, a high that completely was missed. So continuous glucose sensing is now moving into a very prominent part of the treatment of diabetes. Sensors now are being improved continuously. This is an example of what a sensor receiver looks like. So this is not the sensor itself, this is the receiver, and this is the graphic that's actually being seen. Each of these little dots represent actually an every 5-minute average point of time of glucose, as the sensor actually is sending information every 30 seconds. So if we, I think, had an every 30-second reading, we'd all go a little crazy, but every 5 minutes actually is depicted. You can set a high, you can set a low threshold, and so you can follow to see what happens. So that as this particular person has a blood sugar that's beginning to fall, you don't wait until symptoms tell you you need to be checking your blood sugar. Seeing this, you know that you should probably be getting something to eat and maybe giving a little bit less insulin if this was a meal that was being ingested here. Down here, again, knowing that you need to get some food. Again, you may or may not be symptomatic, but you're seeing this trend. The trend's going up. So it's a trend rather than an actual visualization of blood sugars, even though a blood sugar will appear. It's a trend because the measurement is off fluid that's under the skin. It's not actually blood itself. So there's always a little bit of delay in the blood sugar level that will be under the skin as compared to the fingertips. So we often still recommend, if people are seeing this kind of a fall, that they actually double check to see where they are with a finger stick. So it's not a perfect system yet. Clearly, one would like to combine the sensor and the pump, and this just came out actually in the past year, where the pump and the sensor talk to each other. And they talk in terms of shutting the pump off. If you don't tell the pump, I know I'm going low, don't worry about it, I'll take care of myself. You can imagine this has really made a huge difference for those individuals that really can't tell that they're going low. The pump will actually turn off in the middle of the night, turns off for 2 hours. Interestingly enough, that was found to be kind of the magic period of time, and then turns back on automatically. Unless, again, the person says, I know I'm going low, you've warned me I'm going low, I can take care of it, don't turn off. And this is what something like this may look at in a person who has the sensor here, and it's then transmitting glucoses to this little screen here, which then enables the insulin delivery to continue or to actually be stopped. The problem, again, is as we get this technology, the cost, as you can imagine, goes up. And insulin pumps are not inexpensive. The initial outlay is in the range, oftentimes, of somewhere in the $6,000 to $7,000 range, and it requires ongoing replacement of tubing, insulin reservoirs. It's not an inexpensive problem to deal with. Sensors at this time, unfortunately, are not covered by Medicare. Another big problem that we have. And again, sensor devices currently are not inexpensive. So a sensor that I showed you before, it may be in the range of somewhere about $70 at the very best to maybe $100 to even more. Sometimes it depends on the time of year and the particular company. So this is something that's going to be coming down the line that we're all kind of excited about, that will make sensor technology, I think, a lot more feasible. This is already available in Europe. It's by a company that does meters, Freestyle. But what this does is it allows the ability to have a sensor. This is the sensor itself. You can see it's relatively small, about the size of a quarter. The actual sensor is a little piece of metal that goes and is pierced through the skin. Actually very comfortable. You have a little device that helps pierce it through the skin. This particular sensor does not require calibration. This particular sensor can be worn for 2 weeks before having to be tossed, so already there's a cost savings. And what you do is you run this little receiver over the sensor to actually get the blood sugar result and a trend, this arrow as to whether you're stable, going up, going down, And you have the ability here on this little screen, if you can see this, actually looking at the tracking over time as to what the blood sugar was doing. So it's actually a very, very clever device that, as I mentioned, is already being used in Europe. It's so popular that they have difficulty keeping it in stock. It surprised the company. But this will help, certainly with regard to something that's affordable, and we hope actually allow people, again, much better control over their blood sugars. Why am I spending all this time? Well, because this is where everyone with type 1 diabetes is greatly interested. This is the type of graphic that we had when finger sticks are all that are available, and you look at this and you toss your head and say, oh my goodness, what am I going to do about this? This is impossible. It's all over the place. In contrast, when you begin to look at continuous sensing, this is the type of profile you might see in that particular individual. This is with 1 month of sensing, and each of these different colored kind of tracings, if you can follow through, midnight to midnight are 1 day. So here's the one in green, but you can see there are highs, there are lows. So here, a person spent a whole bunch of hours at 250, 270. Then the next day, they actually dipped down into the 50s, the 40s here. This is during nighttime, and this is all over the place. 6 months after learning from the information, what food choices should I make? Should I adjust my insulin dose up? Should I adjust it down? What does exercise do? You can see that they're beginning to tighten up that variability. If you look at a person who's on a pump and now has a sensor, this is before, or just with the sensor added, again, very wild. We're having a high here, we're having lows down here, after meal highs all over the place, and you look at this, and again, you toss your head and say, oh my goodness, what am I going to do? Well, again, the combined sensor and pump delivery allows one the ability to then look and dramatically improve the control. I mean, it's not perfect. You know, there still are some obvious highs here, but clearly I don't think anyone would say that this is not an improvement from what you saw here overnight. So there's a lot of interest in further making this what's now being called the bionic or artificial pancreas, where you have the sensor that senses blood sugar, you have the delivery of insulin, and maybe also have a delivery of glucagon to prevent the lows or treat the lows when those occur. So a lot of interest in this going on right now. We can also take a look at what people are doing, and sometimes actually go over their judgment. And kind of, as one patient put it, there's nothing hidden anymore in my diabetes, and that is right. So just to kind of show you what's going on here, again, here's that sensor kind of tracing that you see up in that. They're looking at blood sugars by finger stick to corroborate that the sensor is reading correctly with these little black lines. And you can see this is a person who, again, from midnight to midnight, so it's a course of 1 day, the sensor went off here, that there's a little alarm going high. The person woke up, recognized it, gave themselves a little bit of a bolus of insulin here, which is what this represents. Probably got a little too excited, didn't make the right judgment, because you can see they didn't stop with just one bolus. Here's a bigger one. Here's an even bigger bolus. So not surprisingly, the blood sugar begins to fall. They hit a low. Again, sensor, sensor, sensor. Takes a while for the person to wake up at 4 a.m. before they recognize that maybe they should turn the pump off. But they go back to bed and forget that they need to get up, because now the insulin is stopped. And what do you see? Again, the blood sugar begins to go up. Again, the alarm goes off. They finally wake up. Oh my gosh, I got to turn that pump back on again. So you can see, you can follow through all the decision-making process in terms of, was it appropriate for you to turn the pump off? Should you not have decreased the rate a little bit? Did you have to give as much insulin here as you thought you needed? So all of these things can actually be tracked with a really amazing precision. Again, nothing is hidden in this realm. So why do we want better delivery of insulin? Why do we want better blood sugar control? Well, as I mentioned, this is our big concern. We're really wanting to prevent complications. That has to be number one. Number two and number three goal. The acute complications, I'm sorry, this got kind of jumbled in the transmission here, are certainly to prevent infections, keeping people out of ketoacidosis. But we also are concerned regarding long-term potential side effects. Retinopathy from diabetes is still number one. And granted, mixed in with that is also type 2 diabetes and retinopathy incidence. But this is the reason that we screen. We screen people with type 1 diabetes 5 years after the diagnosis because it's unlikely that they will have any retinopathy. I didn't say completely impossible, but I said it's unlikely that they would have retinopathy at the time of diagnosis. And also there's something about pre-puberty period of time that seems to protect. But after that, it's really yearly, in contrast to type 2, where we sometimes kind of say, well, we don't have to do it quite so often unless there are specific conditions, such as renal involvement, kidney involvement, or poor metabolic control. One thing that's specific to individuals with type 1 that's not recognized is that if they indeed have their disease 25 years or longer, and this relates both to the eye as well as to the kidney, they actually are less likely to develop eye and kidney problems. There's something, remember that metabolic memory I talked about? Well, that metabolic memory actually can protect people. So 25 years after the diagnosis, and not impossible, but the risk of actually retinopathy and nephropathy falls off considerably. So what do we look for in the eye? So this is looking through the pupil at the back of the eye, the vessels of the eye. And for those of you who see patients, I would encourage you to actually make yourself comfortable with looking at the back of the eye. It's amazing how many people will not follow through on eye exams as routinely as they should, for many reasons, oftentimes cost. Just don't want to make the appointment. I don't want to know. I'm seeing well, so there can't be any problem. If I see well, there can't be a problem. And then you look in the back of the eye and you see something like this. We look for damage. So things such as a big bleed here from leaky blood vessels. We look also at this clustering of blood vessels, which are vessels that are newly formed to try and work around a blockage. These, however, are extremely fragile and they tend to bleed easily. So you see little bleeds like this, not infrequent, but you hope not to see a big bleed or a larger bleed. This person had fully preserved vision. They had no idea that there was anything going on. Again, a reason to look in the eyes, or encourage certainly optimally for individuals to see an ophthalmologist. Again, this is a little bit more progression as you see this clustering develop. High risk for these kinds of clusters and nets to bleed, nets of vessels to bleed. This is when you start seeing infarcts of the vessels, these little tiny vessels infarct, and then you're left with this kind of a whitish appearance. And this you hope you don't see, but this person clearly will be coming in with visual deficit. So this is a huge blood clot that developed from bleeding of those fragile vessels. Sometimes the vision actually can, despite this huge clot, be relatively preserved. And what we usually do is let that clot kind of develop into something that's more organized, and then it actually can be sucked out. And vision can surprisingly be still well preserved. But this, again, is something you don't want to see. There are no guarantees that vision indeed will be back to normal. So how are we doing with this? Well, again, we are seeing less problems with the eyes. You can see over time. These are studies from one decade, the 70s to the 80s now into the late 2000s. And it's nice to see this kind of progression. We also, as I mentioned already, are seeing changes in mortality. We can look at this in various populations. This actually is, again, from a Scandinavian group that has looked at the development of retinopathy over specific to when that diagnosis was made. So if a diagnosis was made early, like back in the 1960s, when we weren't quite so aggressive with our control, versus when it's been made now in the 1980s, when we are more aggressive, you can see the difference in development of retinopathy for the same time and duration of diabetes. We can equally look at kidney problems. So again, 30 to 40% of people with type 1 diabetes will develop kidney problems, although it does look like this may be an incidence that's finally beginning to fall. in contrast to fewer people with type 2, but we just see more people with type 2. Protein in the urine is the earliest marker, and we oftentimes refer to that as the microalbumin to creatinine ratio. But this is a test that's easy to do. Just go to the lab, leave a urine sample. It has, however, many false positives, so you don't want to tell somebody that because they have protein, they immediately have kidney damage. If someone's exercised vigorously the day before, if someone has a urinary tract infection, they had a steak dinner the night before. Hypertensive or poor blood sugar control can result in a false positive. So this is something you want to do on at least 2 or 3 separate occasions to confirm the diagnosis. And again, you see that same kind of progress with regard to the kidney, where again we're seeing much less kidney damage as time goes on, in contrast to when before we kind of let things go a bit more. This is just a graphic with a lot of data on it and it's small print, so I don't feel people need to be remembering this to any degree, but it just shows the degree of the variety of different kind of nerve problems that people can develop with all sorts of issues regarding a fast resting heart rate, or it may be a post-meal sweating, or it may be changes in the degree or the quickness of emptying of the stomach. So these are complications that we've not made quite, unfortunately, the progress that we would like to, but are worth certainly screening for when you see the person with type 1 diabetes. One thing that's easy to do is to look actually at the stiffness of the joints, and it's an easy test to do. You might want to just do it yourself right now. If you take your 2 hands and actually put them together with the palms down and the fingers touching, those fingers and those palms are touching completely. In contrast to this person, where you notice there's a space here. That person cannot approximate their fingers together. It's impossible. And if you had an opportunity to look down here, you'd also see that they just can't get the palms together either. The joints are stiff. It's an easy test to do to look for the changes associated with diabetes, high blood sugars, and joints. So given all this information, what do we know that's specific to individuals with type 1 diabetes? And we're learning a lot from this type 1 exchange. This is something that just began in the past several years. It's a voluntary registry of individuals with type 1. I think there are now some 20 to 25,000 individuals across the U.S. that have actually registered for this. And it's really a means of following individuals. So if you look actually at those individuals who are in the 50 to 65-year range, so about 2,000 individuals, their mean A1C, self-report, but with some ability to actually look at chart reviews too, is generally 7.7%. So interestingly enough, we're seeing a little bit of more movement away from that 8% that I mentioned in that DCCT follow-up. Unfortunately, the concern is this group, 11%, still having an A1C that's equal to or over 9%. They're testing a lot, at least they're reporting. This is self-report, so I kind of always enjoy a little skepticism here, but it's a lot. If we look at those individuals over 65 years of age, look at this A1C. Amazingly, they're doing better, and probably doing better because some of these individuals, again diagnosed later, may still have some residual insulin that they're producing. Clearly, many, over 52%, less than 7.5%, and less of them having very poor control. And they're testing just as frequently. Just because you're over the age of 65 doesn't mean that you decrease your frequency of monitoring. People want to know. So those who do check more often, not surprisingly, had better A1C levels, whether you used a pump or whether you used injection. Diabetic ketoacidosis, you remember, those are one of the complications we really want to avoid, was actually lower in those with increasing age, not associated with duration of diabetes, but it was more likely to occur in those individuals with poorer control, and unfortunately also with a lower socioeconomic status. Again, no difference in diabetic ketoacidosis between pump users or those with insulin injections. Hypoglycemia, and we'll talk again a little bit in these particular individuals. Remember that this is something we are concerned about, we are beginning to learn, is being associated with cardiac abnormalities, specifically arrhythmias, and may actually be associated with some brain cognitive function fall-off. Hypoglycemia unawareness, again, more of concern in those in the elderly because it's now known to be associated with increased risk of falls, itself a big problem in the elderly population, certainly cognitive impairments and cardiovascular disease. There is a problem in that what protects many individuals with type 1 diabetes against the low blood sugar effects, what triggers you to know that I'm going low, is the production of the counter-regulatory hormones. Your epinephrine goes up, your cortisol level goes up, but age alone actually diminishes this and makes this a little bit more of concern. And I think one has to recognize that we may not see the classic signs of low blood sugar. It may not be the person who's sweating, the person who's having palpitations. They may be falling, or they may be having difficulty telling you what's going on. Balance may be an issue. It may be a sign of hypoglycemia in the older person with type 1. So look for the non-classic symptoms. Again, going back to that big exchange that I mentioned, that registry, interestingly enough, look at this. Almost 20% of individuals that had diabetes that were over the age of 40, and again, a little smaller number that reported this. Some of these are just because the numbers are different from the previous set because of different questions that are asked of individuals. But 20% reported having had a seizure or a loss of consciousness in the previous 12 months. And the duration of diabetes and its occurrence, specifically of hypoglycemia, was certainly related to duration, but also lower education status, lower household income, lack of private insurance, and ethnicity began to play a role too, probably because ethnicity also is associated with these other variables. Injection users, more severe hypoglycemia than pump users, interestingly enough, so perhaps pumps are a little safer. This is inferred from the data in older individuals. And clearly, the lower the A1C or the more normal the target for blood sugars, clearly that may actually be advantageous to individuals in contrast to what one might think. This has also been supported by UK, the United Kingdom hypoglycemia study, again, looking at not particularly an older individual cohort, I would think, but certainly individuals that are not in their adolescent years. And again, I just want to point out this 46% prevalence of severe hypoglycemia. This is hypoglycemia requiring assistance. And with A1Cs that were respectable. And their finding was that this tend to occur in those individuals more likely to have kidney disease, nerve problems, depression, certain medications, beta blockers, not uncommonly used for people in their older years for blood pressure control or cardiac arrhythmias. And notice this also is a factor. Again, something we don't oftentimes tend to screen for, ask in our older patients. So I think, again, this is something we're beginning to learn about because of the continuous glucose monitoring. Finger sticks just don't give us the full picture. We would certainly like to see continuous glucose monitoring being offered to a Medicare plus age range. We're working hard to try and accomplish this, but we're not quite there yet. So challenges specific to the older adult, and I think you have these all in your outline. I won't go over all of them, but clearly we need to be alert to what the person can actually learn and how they are best learners. Some people learn better from visual models, some people learn better reading. I think we have to keep in mind that that's something that is individual. We also need to look at whether we're making something very, very difficult versus something that might be simpler, a mixture of insulins versus the individual insulins that I mentioned, basal, bolus, prandial. They may need some assistance in being able to give insulin. Then they may also need to have a more regimented approach to lifestyle, not the flexibility that someone may have who may not have all of these challenges. Certainly vision impairment, I think, is really something very critical in the older age. And I've seen individuals not recognizing that they're losing vision, bringing in syringes where the markings have been worn off, but they're kind of guessing how much insulin they should give because they're frugal. They don't want to spend the money, even though these are not expensive items. They're still at some cost. So it's a challenge and sometimes a very educational experience to have someone draw up their insulin in front of you to see exactly what's being done. There are various ways, such as using dark-colored paper under the syringe to see the syringe tip. Certainly, hearing can also be a problem. You thought you just went over this whole long teaching session, and not a word was heard because the hearing aid battery is gone, and the person's too embarrassed to tell you. There are many devices out. This is actually a very simple clip-on device. It's, I think, like $2, $3 to actually clip on. You clip it on to the syringe, and you actually have a little area where you can clip on the vial of insulin up above. So it will magnify the units. The person's easier to see just how many units. And everything is in one. So even if you're a little shaky, you have everything actually in one kind of combined, connected process to be able to give insulin. I mentioned the pens before, and there are more and more pens. The problem is that although they look like they're all different colors, sometimes that can be a little bit of a challenge in that they're not quite so defined. Our pharmaceutical colleagues are making every effort to try and change some of the colors to make it a little bit more of an alert as to what's a longer versus a shorter acting insulin, but this continues to be a challenge oftentimes. And then I think looking at a patch pump. This is actually a pump that is used for one day. It is placed on the skin. It has a constant delivery. It comes in 3 different concentrations or amounts of insulin. And then this little device here, you actually then push to give a delivery of insulin. So it's a little limited in that there's only a certain amount of insulin in here, but for many individuals this also has been very helpful. They don't have to have the stigmata of an injection or a syringe device. Certainly, if we can make much of our prescriptive other medications easier, I think clearly we do need to always think of discontinuation of inappropriate medications. Insulin can't be discontinued, but sometimes other medications certainly can be either discontinued or simplified or go to a once daily approach to make it easier. We also need to be aware, as I mentioned, of what hypoglycemia means to that individual. How are they perceiving it? What are the symptoms that they need to be on the lookout for? Dietary counseling, again, hugely important. Many individuals have developed habits over the years, as most of us have, and I'm not going to change. I'm going to have that rice. That's part of my cultural. I can't not have rice, and I'm going to eat it. So these are sometimes challenges to work around, recognizing that we still need to respect the person's wishes, but encouraging them sometimes to look at portion sizes or switch to other, perhaps brand products. We oftentimes will use plastic food models. I know we're close to dinner here, but these are not real items. They're plastic food models, and they allow us the ability to actually talk to people about what a portion is. I see many individuals struggling with this, not alone even talking about carbohydrates, which particularly I think for males is an almost impossible concept. It just can't, like, I'm not going to, in fact, I had a conversation with one individual this morning about, you want me to count carbohydrates? I'm not going to do that, period. There's no negotiation. But at least you can talk in terms of what would be a regular portion versus a larger or smaller portion, and leave it at portion rather than actually counting carbs. A plain paper plate or a plastic plate, and we can actually put some colored sections on here in terms of looking at might be an ideal dietary intake, and then labeling these in terms of what can increase sugar, which is what will not increase blood sugar, can also be very helpful. As I say, some people learn much better when they actually have a graphic. And again, I think sometimes just looking at what family resources there are, is this so stressful that they just can't go out because they can't be seen with a syringe or any kind of device giving insulin. I think those are the types of things that sometimes take a lot of time, but really are very, very rewarding. We are now beginning to look at different kinds of goals for individuals that are healthy versus those that are frail or in poor health. This is quite new. You'll notice that those early recommendations I made are now being adjusted for different patient populations. We can look also at the other factors relating to diabetes, blood pressure, equally adjust them according to health, frailty. And I think we also have to always look at the issues that are quite so obvious. Literacy, again, the embarrassment of I can't read or I don't know numbers, and we certainly see this in our clinic. Sometimes only after a long period of time will the patient acknowledge this. Income I've touched on, comprehension level, denial of disease. My doctor thinks I have diabetes, but I don't. Why do you think you're giving insulin? It's amazing the power of denial in individuals. Technology averse. What is this meter? Am I really wanting to use this? The social isolation and the fear that I already have alluded to. So I think those, again, are factors that require some additional effort to identify and then obviously address. And I think this is something to keep in mind, particularly for our older population, that sometimes the best thing you can do is just to sit and listen, not come in with the agenda of, you got to get your blood sugar under control, you got to get your blood pressure under control, we need to get your eyes checked, we need to get the labs done. I see this in sometimes my trainees, and we have a discussion about, well, let's talk about what's important to the patient rather than to you. It's a great conversation, and I think that they all learn from it, but I do think that we have to keep this in mind. And with this, I'm going to thank you for your attention and your interest.
Questions here while we're waiting for the sites to come up? Do you have time for a few questions?
Yes, absolutely.
When is the best time relative to a meal to try to catch those high excursions?
Yeah, it's actually a very good question. We have learned that even fast insulin, which is the meal insulin we tend to use, whether it's Novolog, Humalog, or glulisine, really is very slow to act in the body. So the earlier recommendations, just wait until you're ready to eat, probably weren't very good. Giving insulin before the meal tends to minimize the highs, and it also minimizes the lows. So that what you're seeing is, here I'm eating, my blood sugar is beginning to go up. If I give my insulin at the same time, my insulin's going to kick in over here. So here's my high blood sugar, and I'm sorry people can't see this, but here's where the insulin kicks in. So I've missed treating my high, and I now have a low back here that I need to worry about because the food's already being processed.
And questions come from this room, if you could repeat them.
Okay, so I don't know if everyone heard it, but the question was, what's the ideal time to consider giving insulin? And we talked about pre-meal because of the lag effect of insulin actually having an effect. Now, the problem with that is you have somebody who says, I'm going to eat this, and then they look at this and they say, oh my God, I'm not going to eat this at all. Now you have insulin in the system, and you're ending up chasing it, obviously, with whatever you can. And sometimes the person may just not feel good for other reasons. They're nauseated because of chemotherapy or other things. You then basically have to give it with the meal or even after a meal when you see what's been ingested. It's not ideal. It's going to be very hard to get any kind of consistency in glucose control that way, but it sometimes is the only way to prevent a low.
And the Alzheimer's Resource of Alaska is wondering if there is such a thing as brittle diabetic.
Yeah, it's a very good question. It's a terminology we used to use not infrequently in the past. And as it turns out, most people are not brittle. It's referring to the ups and downs of blood sugar responses to insulin. Sometimes it's a dosing issue. We just talked about timing. A very common problem with timing of insulin being inappropriate, dosing of insulin being inappropriate. There is the occasional person, no matter how hard you try, that it just doesn't work. You're making all sorts of adjustments, food-wise, insulin types, insulin timing, and it still is very difficult, but that's going to be the relatively rarer person.
What do you know about the usefulness of healthy plant-based diet in preventing complications in type 1 diabetes?
Not very much. That's a very good question. We certainly know more in the type 2 individual, the person with type 2 diabetes, but with a type 1, it's a very difficult situation because, again, you're really relying on insulin. Having said that, is it a bad idea to have a vegetable-based diet, a Mediterranean type of diet? Well, of course it's not. It's a very healthy diet for everybody, and one wouldn't expect it to be any less so in the person with type 1 diabetes, and we do actually advocate it. We have many people who are vegetarians, but we also have many people who enjoy their protein products and their hamburgers, and we work around that also.
I have a question. Does Medicare cover the insulin pens?
The question was, does Medicare cover the insulin pens? Yes and no. It depends on what they have for Part D. Some will not. Some will with prior authorization. It's very rare that you have someone saying absolutely not, unless it's a very, very basic insurance Part D.
Is there anything new in regards to islet cell transplant?
So the question is about islet cell transplants, and right now they're probably kind of at a plateau. There was a lot of interest, actually almost a decade ago, in thinking that we had finally the right procedure with the right amount of cells and the right immunosuppressive regimen, and then found that these perfect so-called transplants, if you want to call it that, petered out after about 2 or 3 years. And it wasn't rejection. It's actually something else that went on that just gummed up the cells, if you want to call it, or something interfered with the production of insulin. And so people said, well, that's okay. 2 or 3 years, get another transplant. That isn't as simple as it seems. Plus, you have to guarantee that you can get these cells to transplant the islet cells. So although it's by no means given up, and there is actually some interest in a capsule form underneath the skin, that may actually have kind of resurgence in interest probably in the upcoming year.
The type of joint damage is related to type 1 diabetes?
It's probably related to glucose, sugar, actually attaching to various components of the joint. So in the joint capsule, the ligaments, the capsule itself, that you actually have glucose attaching to the tissues, and then that allows or facilitates the stiffness that occurs. So it's not that these people have outright rheumatoid arthritis or lupus, although they certainly are at risk of that because one autoimmune disease predisposes you to a higher risk of other autoimmune diseases, but it's really more of a stiffness than arthritis. Very, very common.
Someone from Anchorage is saying, I was diagnosed with prediabetes this past summer and was able to beat it with weight loss and by reducing my sugar intake. How much sugar should we eat a day? Mine is down to about 35 per day. I was told if it has 9 grams of sugar, don't buy it or eat it. It seemed to work for me.
Well, those are good questions. I don't know that there is a statement that can be made that would work for everybody. Obviously, the program that this person started worked for them. We typically advise, depending on physical activity, roughly for the average person, somewhere in the range of about 50 to 55 grams of carbohydrate per meal as a good way of minimizing some of the glucose fluctuations. Clearly, if the person's very active, they're out digging ditches, planting trees, you can increase that very significantly. And they will need actually more calories, which have to come from carb. So I think this has to be individual for each person in terms of what works, what's dependent on their physical activity. And clearly, prediabetes most likely makes you, quite frankly, not at risk for type 1, but for type 2 diabetes. So calorie restriction in addition to carb restriction really needs to be combined.
Other questions here?
The theory that you talked about earlier, the etiology of type 1 diabetes and the environmental attack followed by the insult followed by the autoimmune attack. Is there a similar process, do you think, in thyroid and like Hashimoto's?
Yeah, it's a great question. There is some. Oh, I'm sorry. The question related to the process in developing type 1 diabetes. That whole process I mentioned, genetic risk, and then there's an environmental insult or trigger, and then that actually facilitates the autoimmune system attacking the cells. And this is something that we haven't thought about in thyroid generally, or other diseases such as adrenal function failure, but is actually enjoying some interest, looking at whether indeed this is indeed the same kind of process, and whether it may be multiple hits for those particular organs that also are in place. So yes, there's a lot of interest recently in that same kind of understanding. Is it the mechanism or not?
So Peninsula College says, what is your opinion of switching from Lantus or Levemir to NPH insulin when the patient is in the Medicare Part D donut hole?
Yeah. It's something we're doing more and more, not necessarily only because of the donut hole, but from Lantus and Levemir, if the person's requiring a lot of insulin, and again, we have individuals who look like they're type 2, require a ton of insulin. I actually have an individual who's almost 400 pounds and was told by her physician, well, you should just stop the insulin. And fortunately, she understood that she had type 1 based on her antibodies and said, I can't. But this is an individual who takes a huge amount of insulin, somewhat close to about 300 units a day. That's a huge expense, and sometimes to get around that expense, we indeed look at NPH. In fact, we just did a study not long ago looking at what happens switching from Lantus to NPH with regard to cost savings. They did use a little bit more NPH. There is a risk of